Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. And today we are going to dive into yet another primary snippet. So, Maddie, this is a pharmacology snippet, and we're talking about some antiarrhythmic agents. Can you please compare and contrast metoprolol and verapamil with regards to their class, indications, mechanism of action, and pharmacodynamics?
Yep, so I think also have a look at the show notes because it probably works better like in a table form in terms of consolidating the information. But in terms of the class, metoprolol is a selective beta-1 blocker with no intrinsic sympathomimetic activity or brain stabilizing effect, whereas verapamil is a non-dihydropyridine calcium channel blocker. In terms of the indications for use, they both can be used for hypertension. Metoprolol can be is either as a single agent or in combination with other antihypertensives. They both can be used for tachyarrhythmias, namely atrial fibrillation or flutter, SVT. Metoprolol can be used for VT, such as sustained or VT storm, in addition to an antiarrhythmic drug, or for prevention of further VT. Whereas verapamil is not used for VT. So verapamil is just used for supraventricular tachycardias. Metoprolol is also indicated in the long-term prophylaxis of angina pectoris, but it's generally contraindicated in vasospastic angina as it can exacerbate this. And verapamil can also be used for treatment of angina at rest, including chronic stable angina, and it can be used for vasospastic angina and for unstable angina. Metoprolol can also be used in one of the other indications is myocardial infarction for early treatment and secondary prevention. We know that it does help with cardiac remodeling, and for chronic heart failure with reduced ejection fraction, but in their stable phase, not in the acute decompensation. One of the consultants I work with, that's a big bugbear, people starting metoprolol too early in cardiogenic shock. And then finally, metoprolol is used for migraine prophylaxis, and verapamil can also be used for prophylaxis of cluster headaches. Then coming to the mechanism of action. So metoprolol binds the GS protein coupled beta-1 receptors. This blocks cyclic AMP synthesis, which reduces protein kinase, and then this reduces the phosphorylation of membrane L-type calcium channels and the release of calcium from the sarcoplasmic reticulum. Verapamil binds to the specific area of the alpha-1 subunit of L-type calcium channels, which inhibit calcium influx into the cells. So they both work eventually on calcium, just by different mechanisms. In terms of pharmacodynamics and adverse effects, so I've just broken this up in terms of initially cardiovascular. So in terms of cardiovascular effects, so metoprolol decreases from a heart rate point and rhythm point of view, decreases the slope of phase 4 of the nodal action potential, which is a primary determinant of heart rate. So this reduces the firing of pacemaker cells and reduces heart rate. And it prolongs repolarization of phase 3 in the nodal action potential, which increases the refractory period and reduces excitability and conduction velocity. So this results in decreased heart rate and decreased myocardial oxygen demand. Verapamil increases the length of the phase 0 of the nodal action potential, which slows the conduction velocity in a rate-related manner. And it prolongs the phase 2 of the action potential, which is a plateau phase, which also prolongs the effective refractory period within the AV node. And this also results in a decreased heart rate and a reduced risk of arrhythmia. Both of them, because of an extension of these effects, can cause bradyarrhythmias, sinus causes, or different levels of conduction defects, such as complete heart block. For verapamil, it can also precipitate VT or VF in those with AF and coexisting accessory pathways. From a contractility point of view, they both inhibit calcium influx through L-type channel. So they reduce the catecholamine effect on the heart and reduce its contractility, which can then precipitate cardiac failure in certain patients as an extension of this mechanism of action. From a SVR point of view, metoprolol causes an initial increase in SVR, which reduces with time, and this can exacerbate peripheral vascular disease and Quinns-Bexell angina. And verapamil inhibits the L-type calcium channels, which prevents the contraction of vascular smooth muscle and causes dilatation of vessels and thus decreases SVR. An extension of that can be peripheral edema as an adverse effect. And from a blood pressure point of view, both of them decrease blood pressure. Verapamil mainly does this through vasodilation, whereas metoprolol does this through decreased contractility, decreased heart rate, inhibition of renin secretion, and inhibition of the vasomotor centers. And as an extension of these effects, both can cause hypotension. There are also other systemic effects. So in terms of adverse effects, so metoprolol can cause bronchospasm, but it's like less common due to the beta-1 selective effects. gastrointestinally, both can cause nausea and abdominal pain and elevated transaminases. The metoprolol can cause insomnia and nightmares, but verapamil can decrease the neurological transmission in patients with Duchenne's muscular dystrophy. And metoprolol, because of its effect in terms of the catecholamines, it can mask the signs of hypoglycemia and mask signs of hyperthyroidism. And they both finally, as most medications, can rarely result in hypersensitivity reactions.
Thanks, Maddie. So that's the end of our today's snippet. We'll be back with another snippet in a few weeks' time. Till then, goodbye and have a nice time.
Thanks for listening and see you next time.